How do you choose which regimen you're going to use? I mean, is it simply a side effect profile? Is it virologic effectiveness? What? Where do you start?
I'll let you answer that.
Well, first of all, I think it's fair to say if people took 100% of their medicine, all the regimens will work.
No matter what it was.
It doesn't matter what it is, if they take 100% of their medicines. So we have to, think about all of those factors. What are the potential side effects? And have a discussion with patients. And some patients may say, well, I could handle that, but this particular side effect, if I even get a little bit of it, that would not be good for me. So we have a discussion. Mental illness is a big thing that plays a part in our patient population, and comorbid mental illness along with HIV can play a factor with potential adherence. And
you could roll into that the known association for HIV-associated dementia too, which would make compliance more difficult.
Absolutely. And that might lead you down the path of starting off with a regimen that we refer to as having a higher genetic barrier to resistance, having more difficulty to develop resistance should there be missed doses.
And I'll just say the question you asked is the same question that payers have.
Mm-hmm.
What's that?
Is when we go to providers, is we're trying to figure out how we can manage this, is how do you decide which drug or which regimen, which STR, whatever, is the best for each patient? Because what we're trying to do is again, put together a formulary that is best for the population, knowing that there's always going to be a pathway for specific patients. Mm-hmm. So again, the formularies are population tools. Generally speaking, payers just try to manage. We don't want to practice medicine. We're just trying to manage maybe that first choice. Can we come to some kind of consensus on maybe what are the appropriate first-line drugs, and beyond that, we're not going to get down to that level, because that is a provider decision, and that's not something that we're educated enough to really play in.
All right, well, we have this term of art, this most patients term, which is what the guidelines address. And then they say there's a carve out for patients that don't fit the most patient category. You already alluded to psychiatric illness. We brought up dementia. Are there others what are the other cutouts?
So, for example, pregnancy.
How so?
You would need to avoid elvitegravir and cobicistat, which is actually it's an integrase inhibitor, which would be considered in the recommended. That would be a drug that has to be avoided. So those are some things to think about. Chronic kidney disease. So there's new products that are actually safer for kidney disease, the TAF products. So you would focus which medication you would use.
What about those patients who come in, and I'm not going to say exceptionally sick, because I'm not sure if this correlates directly to symptoms one-on-one, but clearly worrisome. Very high CD4 counts or very low T4 cell counts. Is that part of the carve-out?
I think we have to consider that. Integrase inhibitors have been a wonderful addition to the classes of drugs that we have to use. But more recently, there's been data that's presented at the retroviral conference this past year from some large cohort studies, which showed that people with very advanced disease that get started on an integrase inhibitor-based regimen have higher rates of immune reconstitution syndrome, which was so concerning of the authors that they suggested that perhaps people with more advanced disease should start on a non-integrase inhibitor-based regimen, perhaps a protease inhibitor-based regimen because of this.
Well, bring us into this. What is immune reconstitution syndrome?
Well, when somebody's immune system is severely suppressed or depressed from advanced HIV disease, and then they respond very dramatically to a reduction in their virus, and then their immune system gets strong very rapidly, there can actually be a very prominent immune reaction that's a direct result of the immune system getting strong very rapidly. And it can cause an inflammatory response in many different organs. Not necessarily a disease, but an inflammation related to a strengthening of the immune system due to immune reconstitution from effective therapy.
I mean, that's something we never even considered so many decades ago. What does this look like? Does it look like SIRS or sepsis? Or what does the actual syndrome look like?
Well, people can have fever, they can have inflammation, evidenced by, let's say, some liver enzyme elevation. It can be very prominent. It's something that's been clearly identified in initial therapy, and because integrase inhibitor therapy reduces viral load to a much more rapid degree than other NNRTI and protease inhibitor-based regimens, the thought is that perhaps integrase inhibitor-based regimens might lead to a faster and more robust immune strengthening, which puts people at risk for this
That's fascinating.